Hello and welcome to today's episode of the Pediatric Consult. I'm Dr. Jill Schaffeld, your host for today, and I'm very excited to talk to today's guest, Dr. Cheryl Bayart, with the Division of Dermatology at Cincinnati Children's. Welcome, Dr. Bayart.
Thanks so much for having me.
Thanks for joining us. Today's discussion will be about infantile hemangiomas. So let's get started and kind of jump in by learning a little bit about our guest that has joined us today. If you could just share a little bit about your background, maybe how long you've been practicing, how long maybe you've been at Cincinnati Children's, and any special interests you might have.
Sure. Yeah, I've been at Cincinnati Children's since July 2021, so coming up on 4 years now. It's been a lot of fun working at Cincinnati Children's because I have a lot of opportunities to do very specialized multidisciplinary clinics and work with different specialties, as well as to do a lot of pediatric procedures in a variety of settings, which is a passion of mine. So I spend 4 half-days per month typically with the HVMC, which is the Hemangioma and Vascular Malformations Clinic. I also do a joint clinic with rheumatology, and I do quite a bit of laser and also excisions in the operating room. Before Cincinnati Children's, I was at the Cleveland Clinic for 4 years. I did my fellowship at Seattle Children's prior to that.
Wow, so kind of had a taste of training and practicing in all different areas of the U.S., which is cool. That brings a neat perspective here for us today. So thank you again for joining us, and we'll go ahead and kind of jump into our topic. So in talking about hemangiomas in infants, I would say this is something that is so common as a general pediatrician to see. But do you have any thoughts about overall incidence of hemangiomas in infants?
Yeah, so the estimates I've heard are pretty varied for infantile hemangiomas, which are the most common vascular tumor of infancy. I've heard, between 2 and 3%, which I think probably applies more to the population that we as dermatologists see that come to the office with these. But I think that they're probably a lot more common than that. There are many that just, don't need any intervention and maybe are never even addressed by a physician at all, or just, mentioned at a primary care visit. So I think probably I've heard estimates as high as 10%. I suspect the reality is somewhere in the middle.
Sure. I would agree with that. 2 to 3% just in what I see seems very low. So I do think hemangiomas are quite interesting because for me, I feel like when I'm seeing children in the office for well child checks, it's not the newborn visit usually that we're discussing. Oh, what is this spot? So could you talk a little bit about kind of development and timing when hemangiomas usually appear and just kind of typical course as they develop?
Yeah, and you're absolutely right. By definition, infantile hemangiomas are not fully formed at birth, and that is in contrast to the other main type of hemangiomas that we see in babies, which is much more rare, and those are called congenital hemangiomas, and they're totally different. But infantile hemangiomas, there may be something on the skin at birth. Sometimes there's a little bit of what we call a precursor lesion, vascular patch, maybe even a little blanching spot, but definitely not the sort of strawberry hemangioma that we typically think of when we think of an infantile hemangioma. So typically, the most rapid sort of change and proliferation happens between 5.5 and 7.5 weeks of age. So usually we are seeing some growth prior to that, but definitely, not fully formed right at birth. Growth continues typically until about 3 to 6 months of age, sometimes even up to a year of age. And then hemangiomas stop growing. They kind of plateau, and some of them, kind of stay the same size for a while. Some of them shrink rather quickly. We usually say about 30% of hemangiomas have involuted by age 3, 50% by age 5, 70% by age 7, and 90% by age 9.
I've never heard that. I love that.
Yeah.
Makes it kind of easy to remember.
Yeah. I think it's not exact, but close enough that you get the point.
Sure. No, that is great. As you're talking, I'm smiling because I'm thinking, yep, I feel like usually the 2-month visit is when I'm having that first conversation. Maybe there's a little bit there at 1 month, or, I'm telling a parent, oh, I think this might be the beginnings of hemangioma, but really it feels like that 2-month well-child check that we do is when all of a sudden we're having all the hemangioma conversations. So that makes perfect sense that, with the proliferation, you said 5 to 7 weeks was the...
Yeah, there was a study looking at actually serial photos taken by parents,
Wow.
and they found that typically 5.5 to 7.5 weeks of life is sort of the most rapid proliferation.
Yeah, that makes perfect sense with when we see it. And I think that's just even nice data to share with parents, right? So that they understand why it's happening and why it wasn't there, at birth, and that this is an expected thing. So, I think that a lot of this information that you're sharing, which is great, is to help us know how to kind of guide parents and what to expect, right? Because I feel like infantile hemangiomas have such a kind of funny or crazy course, right? With just, it's not there, then it's there, then it really grows, then it stops growing, then it goes away, right? Any thought or guidance? I know you said, 70% by age 7. Is there any portion of those percentages that you would say you would tell parents there's a chance that this would never go away?
For sure. As a rule, pretty much all infantile hemangiomas do involute. They shrink, but they don't all go away without a trace. And I do tell parents that. Sort of risk factors for having, residual, even permanent changes in the skin are having a really big deep component. So hemangiomas can be superficial, which is sort of that bright red plaque, that strawberry hemangioma that we typically think of. They can be deep, which is just a blue swelling. Most of them are mixed. They are a red plaque on top of a blue swelling. And so often the bigger that the deep component is, the more that it can stretch out the underlying tissues. And sometimes it's kind of like when you blow up a balloon and you let out the air and it doesn't quite go back to the way that it was,
Sure.
Especially in areas like the face where there's not a ton of growth versus areas like the trunk. Often there's so much growth that area will stretch out and not be so noticeable. Some can leave behind some cutaneous telangiectasias, just extra blood vessels on the skin, and that's more related to the superficial component. And some can actually cause structural damage based on where they're at. Hemangiomas of the nasal tip, for example, as they grow, they can permanently distort the nasal cartilage. And so they can change structures around them, and for that reason, sometimes they do need to be treated to prevent growth.
Sure, absolutely. So as a pediatrician, maybe at that first checkup, what specific things am I looking for to maybe say, okay, this, and we've touched on a few of these already, but, maybe it's location, characteristics of the hemangioma itself, but what specific things am I looking at to say, okay, I need to be on more high alert. I need to really make sure that we're following this, and as opposed to, hey, this is no big deal, we're just going to watch it, this will most likely go away, that sort of thing.
That's a really great question because the majority of infantile hemangiomas can just be watched by their pediatrician. They don't need a referral to a specialist. They don't need any treatment. But there is a subset of hemangiomas that really should be referred as early in life as possible or started on treatment as early as possible. And those are really the hemangiomas that are at risk for complications. And so I'll talk about sort of the main complications that can happen. The most common is ulceration, where the surface of the hemangioma opens up. It develops an open sore, scabs, bleeds. A lot of parents will worry, when I talk about this as a potential risk and why we're treating, that their child will bleed out because they have this big, vascular lesion, and if it opens, that they will, bleed to death. And that is not the case. There really isn't usually significant bleeding, but it's pretty horribly painful for the child and often leads to permanent scarring when it happens. So, risk factors for ulceration. So, certain locations, areas of friction. So, hemangiomas of the diaper area, we often strongly consider treating because there is stool, urine, friction from the diaper. All those things can contribute to ulceration. Ulceration can happen on the lip from feeding. I've seen ulceration happen in little skin folds and rolls where there's friction as well. Some sort of very plateau-like hemangiomas that, stick far off of the skin are at a little bit higher risk for ulceration as well. So it's a combination of really location and morphology, but thinking, hey, is this in a place where it might open up and bleed?
Sure. Is there any size that, maybe pediatricians should be more alerted by? Like, if it's bigger than this, it is maybe more at risk for ulceration or more at risk for complications.
Yeah, so, it doesn't seem like size necessarily correlates to ulceration. Sort of the other complications that we worry about are functional impairment is another one. So you can imagine an infantile hemangioma on the upper eyelid. If it grows and swells, it is going to shut down the eye. And during a critical period of development, the child is not going to have a normally developing visual access. So eyelid hemangiomas we often treat. Ones that are located on the neck or the beard area, especially if they're extensive, can be a marker for airway hemangiomas. So those patients we send to ENT for scopes, and we treat before the hemangioma proliferates and shuts off their airway. Sort of the last big complication that we think about is permanent disfigurement, and I talked about the nasal tip hemangioma, but often larger hemangiomas on the face in general have more of a risk of leaving behind permanent residua for, the child getting to an age where people are asking about it, where it becomes a psychosocial issue. The other thing to think about in terms of size is segmental hemangiomas, so that are quite large, usually larger than 5 centimeters, and affect a body segment. Those that are located on the head and neck can be a marker for FACE syndrome, which is an acronym that stands for posterior fossa anomalies. Hemangioma, segmental, 5 centimeters or more. A is for arterial anomalies, aortic coarctation. C is for cardiac abnormalities. E is for eye abnormalities and endocrinologic abnormalities, and S is for sternal notching or other sternal anomalies. So most patients who have this syndrome do not have all of the facets of it, but babies who do have a segmental hemangioma, 5 centimeters or more of the head and neck, do need to be referred for workup, which is typically to start with MRI, MRA of the brain and of the neck, as well as an echocardiogram. There is a correlate over the lumbosacral spine called lumbar or sacral, and those patients can have associated renal or genital anomalies.
Oh, wow. Yes. Thank you. Thanks. That's great information. So definitely those large facial kind of head and neck, and then the lumbosacral that you mentioned. How about just amount of hemangiomas? Maybe, I see a baby in the office at 2 months and I'm like, oh, it looks like maybe there's 3 little different spots developing. When should we be worried about maybe the amount of hemangiomas a infant has?
Yeah, skin hemangiomas, rarely in and of themselves cause an issue just because there are too many of them. But the more that you have on the skin, the higher likelihood that you may have visceral hemangiomas that affect the internal organs. So, Usually our sort of the number to keep in mind is 5. So babies that are seen before 5 months of age who have 5 infantile hemangiomas or more warrant a right upper quadrant ultrasound to look for hepatic hemangiomas, so hemangiomas on the liver, which is the most common organ to get hemangiomas. And if we don't find any there, we don't necessarily look further, but they can be in other places too. If we find them, it's not necessarily problematic. Often we will just monitor them, but very large visceral hemangiomas, as they go through that proliferative phase, 5, 6, 7, 8, 9, 10 weeks of age in particular, can actually, shunt enough of the blood away from the heart to cause high output cardiac failure.
Wow.
They can also produce certain endocrinologic abnormalities that lead to hypothyroidism. Once we're past the proliferative phase, about 6 months of age or so, when the growth is done, we're not so worried about that. So if I see a patient at that age that's never been screened and they're fine, I won't necessarily do it. But before then, you want to just check so you know what you're dealing with.
And that sounds like a pretty simple thing that a primary pediatrician could do too. If, there are 5 small hemangiomas on the skin, we can order that ultrasound. And if that ultrasound looks good, you said, it's really okay if those are relatively small and there's no other complications with them, just to follow those. So that's
Absolutely.
great to hear. Yeah. So we have kind of, which is great as things have come up. We've also touched on this a bit, but, greater than 5 with visceral involvement, absolutely we should be referring to a specialist, to you or the team at the Vascular Malformation Clinic for help. We discussed, if the hemangioma is at risk of ulceration, just with the location, like you said, in that beard and neck area. Any other specific circumstances that you can think of to share that you would say, this should really be managed by a specialist as opposed to, watching and waiting with the pediatrician, or we'll go into a little more specific treatment here in a second. But, besides the things you've touched on, any other indications for those referrals to the specialist?
I think those are really the main ones. And to reiterate, it's, risk of ulceration, either, imminent or as it grows. Sometimes before there's ulceration, there may also be some central graying or scabbing, and that's kind of a red flag that ulceration is going to happen. Sometimes ulcerated hemangiomas or ones at risk can be managed with topical timolol. So, some pediatricians may manage those. I would say the ones that, are at risk for functional impairment, on an eyelid or on the neck, or, for example, affecting, the circumferential digits of a hand, could get in the way of the use of the hand, should be referred. As should the ones at risk for permanent disfigurement and the ones at risk for internal complications like face or lumbar syndrome or what we call visceral hemangiomatosis.
Sure. So topical timolol. As a pediatrician, I think I definitely have colleagues that, here and there might prescribe or dabble in it, but I don't by any means feel like it's a widely accepted treatment that most general pediatricians use. So can you discuss maybe just a little guidance on, prescribing in general, dosing, how long, kind of just all the things that might help us as a general pediatrician be more comfortable with starting topical timolol on our patients?
Sure. I'll start by saying that I absolutely love topical timolol. I think it's a wonderful, very low-risk option that is very effective, especially for superficial hemangiomas. It doesn't work as well for the deep component of hemangiomas. So, if you are, just trying to decrease the appearance on the face or decrease risk of ulceration, it's great. If you're worried about one that's deep and is going to distort the tip of the nose, then you really need to go systemic. But timolol is a really great option in a lot of situations. And it really has very few side effects. Sort of the most common one is skin irritation, which I would say is very, very, very rare. It can be absorbed systemically to some degree, and there have been a few studies looking at just how much is absorbed. Some babies do have a slight change in heart rate, blood pressure, but nothing clinically significant as you would have with a systemic beta blocker. Hemangiomas on the scalp seem to absorb a little bit more of the timolol, maybe because there's such a good blood supply, and ulcerated hemangiomas tend to absorb a little bit more of the timolol. So I think it's important to use caution, if you have a very, very, very tiny baby, like a preemie. Sometimes it's better to do systemic to know exactly how much they're getting, rather than say, we'll put 3 drops on this large hemangioma, and 3 drops can be very variable in size, and you're not sure how much you're getting. I did have a patient once get into trouble using timolol on an ulcerated hemangioma on the lip, where it absorbed through the lip and then also was swallowed a little bit. So I'm not a big fan of using it on the lip, especially in an ulcerated area.
That's great. That was actually going to be one of my follow-up questions. Like, well, what about the lip? Because it just seems like it would be so close to the mouth, right?
Yeah, and it's actually, it's an eye drop, so it's extremely concentrated compared to the oral formulations of beta blockers that we use. So if it is going in the mouth, it can be absorbed too much. I typically tell people to use 1 to 2 drops in small babies, max, even if it's a larger hemangioma, just to make sure that we're not getting to the point that we have significant systemic absorption. It comes in a couple different forms. There's a gel-forming solution, which I think is very elegant and easiest to apply, but unfortunately is a lot more expensive. And
of course it is, right?
Yes. And, I sometimes people have trouble getting insurance coverage. I had enough patients that, paid way too much out of pocket for it when there's a very, very inexpensive liquid version. The liquid version is a little bit more unwieldy to kind of drip onto a hemangioma. So I tell patients to get, a little contact lens case and put the drops in there, wash their hands, and then use a clean finger to apply the drops from the contact lens case. I always make sure that the family understands that the medication is supposed to go on the surface of the hemangioma and not into the eye, because this is an eye drop that we have repurposed to, use off-label for treatment of hemangiomas. And I have seen in my training a couple of patients that came in and their hemangiomas weren't responding, and lo and behold, it's because they were putting the medicine in the eyes instead of on the surface of the hemangioma.
Not something that you may think of, but what great advice just to be careful with. Typical dosing just daily, like once a day?
Twice a day. Usually approximately every 12 hours, but it's not important to, be exact with that. I say anywhere between 10 and 14 hours, usually 1 to 2 drops each time. In very small babies or preemies, I do recommend that it's applied after a feed, just because there's that theoretical risk of hypoglycemia with any non-selective beta blocker. Again, it's usually not systemically absorbed in enough quantity to do that, but I just like to be safe.
Sure. And then I assume this may change from infant to infant, but what is the typical duration of treatment, or what kind of endpoint are we looking for on physical exam to say we would stop treatment?
Yeah, so usually, both systemic and topical beta blockers are continued until the proliferative phase is complete, and we think that the child's body has, started in the involution phase and will start to take care of the hemangioma on its own. the initial studies looking at beta blocker treatment for hemangiomas stopped treatment at 3 months, 6 months of age, and we found that if the hemangioma is still programmed to proliferate, it will bounce right back. Even if you've stopped the growth, it will, grow if the beta blockers stopped. So on average, I usually tell parents for topical treatment about a year of age is when we usually try to stop. And if the hemangioma bounces back, then we will restart. Treatment. Some hemangiomas do have some what we call late growth. So they don't, in terms of involuting, follow that course as well as others. So some, bounce back after stopping beta blocker treatment, even until 2, 3, 4 years of age. Those are probably ones that should be referred to a specialist, and that's more the exception than the rule. But you really let the hemangioma's response kind of guide you as to, can we stop now or do we need to start again? But really the only way to know is to try stopping.
Sure. And then in referring to a specialist, we discussed, dermatology is appropriate. Obviously here at Cincinnati Children's, you had mentioned earlier that we have our vascular malformation team, which is multidisciplinary. So that's a good option for referral. At what point after referral, and maybe topical timolol has already been tried by the PCP, what point would you initiate oral propranolol therapy or oral beta blockers?
Yeah, so, sometimes it's my initial treatment. Sometimes we try timolol first. Really, it's, risk of those complications that we talked about. So, ulceration, if, I feel like either topical timolol isn't helping or it's in a place that's not practical to use topical timolol, I will start oral treatment. If there is risk for functional impairment or disfigurement, then I will start oral treatment. If I think that, the hemangioma is most likely going to leave some permanent changes on the skin that will always be obvious, I have a conversation with the parents regarding the risks and benefits of treating with an oral beta blocker early on versus, trying to address that issue if it's bothersome to the child later in life. And some would much rather do, a low-risk systemic medicine early in life than take the chance that their child will, have a birthmark on the skin that people will ask about that they will have to kind of cope with. Some prefer to leave it up to their child. And, if it's not something that is going to require multiple surgeries, maybe it's going to require a little laser treatment, something like that, I really leave it open to the family.
Great. That was actually a great segue as well, because I was going to ask you, you mentioned some of your specialty with like laser treatment. What does that typical patient look like? You obviously just said a lot of patient preference, family preference, for when to use laser, but are most of the lasers you're doing on just very large hemangiomas? Are they more just, more visible hemangiomas, so you feel like the majority of it's cosmetic? Is it, age-wise? I'm very curious. I don't know that, I initially thought, which I guess I should have, but maybe just because I don't see these ongoing for that long very often, laser as a treatment for, stubborn hemangiomas that aren't resolving.
Yeah, and I think the treatment landscape in that regard is in evolution. We know that if, you initiate vascular laser with the pulse dye laser, which is our typical laser that we use for infantile hemangiomas and port wine birthmarks, if you start that early in life during the proliferative phase at high enough settings, you can actually cause ulceration in an infantile hemangioma. And there were several case reports of that, and I think because of that, most people are hesitant to use laser, as first-line treatment for hemangiomas in infancy, especially during the proliferative phase. However, some people are using it as an adjunct to beta blockers, even early in the proliferative phase, just on much gentler settings. That's not something I typically do, just because the laser is somewhat traumatic. It feels like a rubber band snapping on the skin. We have to kind of hold kids, swaddle them. We have to cover their eyes, which they don't like during the treatments. So typically, I recommend laser either, if and when the patient is bothered by the appearance of any, residual telangiectasias, red areas on the skin. If they happen to be 4 years old and they're bothered, even if I think that they're going to continue to fade on their own, I think it's still worth treating. If they're 4 and the child is not bothered, then I usually tell the family, well, why don't you wait more till like 9 or 10, and then, we'll know that the hemangioma has kind of done all that it's going to do naturally, and we can go ahead and treat more. So it really varies, and I think it varies very much depending on the patient and the parent. I always have a very detailed discussion of risks and benefits and make sure that the family understands exactly sort of what is going to happen in the room during the laser treatment, so they can decide if that is the best option for them.
Sure. Well, thank you so much, Dr. Bayart, for sharing all your experience and your expertise with us. I think you've given us some great info and hopefully empowered pediatricians and our broad audience and listeners to be comfortable with, what to watch for, how to guide parents and what to expect, as well as some of the initial treatment, and really to know when we need help from the specialist. So we really appreciate you being here today and sharing all the information with us. And just so our listeners know, this will be available on the main podcast page. There will be a link for CME credit. So I want to thank Dr. Bayart for being here and thank all our listeners as well.
Thanks so much for having me. It was a pleasure.